Cool. Let's start with question 1. All right, guys, I'll give you another 15 more seconds to go through. All right, let's see what people think. So people have gone for 29% A, 29% B, and 29% E, and 14% C. Cool. So I think one thing that's important to mention is that I'm a medical trainee, and I do a lot of emergency medicine. So a lot of the psychiatry stuff that we'll be talking about is probably going to be useful for medicine, but also for your revision for psychiatry. But because a lot of the stuff that you need to know about psychiatry is how it links with the rest of medicine and how you as a junior doctor need to approach patients who have psychiatric conditions. So you'll find through this lecture, I'll be talking about different medical things. So trying to make it a bit more integrated rather than just talk about psychiatry as its own thing, because you can get quite deep into the specialist stuff. But for you as a junior doctor, certainly when you're in F1 or in F2, you need to know the general stuff and how it links with everything else. And I think that's the most important thing. And that's the sort of running theme for this lecture. So the answer here is actually E, urinary toxicology. So it's a 34-year-old who is acting strange, increasingly withdrawn and anxious. She has a family history of schizophrenia and no relevant past medical history. Recent observations are stable and she is afebrile. So let's go through why the other ones aren't correct. So pregnancy test is probably not the best next investigation because it probably doesn't have, being pregnant doesn't really sort of, I suppose in theory you could have psychosis that can be postpartum, but really it's not the most important thing you're going to want to do in this patient who's withdrawn and anxious as well. Blood cultures are not so useful because she's afebrile. There's no obvious sign of infection. You would only really consider that if someone's febrile as they come in. Meningococcal PCR, if someone is psychotic, who's coming in, who's withdrawn and anxious, acting strangely, the first thing you don't think is meningitis, especially if they're afebrile. They could have an encephalitis, possibly, but in that case, it's not the next best investigation. You wouldn't just necessarily do a meningococcal PCR, and that sort of thing would tend to be done, via the cerebrospinal fluid, via lumbar puncture, which is not really the next thing you would do. And equally, an MRI head is not the next thing you would do because it's not the next best investigation. And so the really important thing for someone who has a psychotic episode or psychosis, especially in the emergency department, you need to always try and rule out whether or not they have any evidence of drugs or they've been taking drugs, because on the most part, if someone is psychotic, one of the other very important differentials of psychosis is actually drugs or being high on something. Of course, you can get drug-induced psychosis, which is possible, which sort of helps going forward, but you need to really rule out if they've taken any medications. So that's why you do urine toxicology. So I want to talk about schizophrenia because it's the sort of classic sort of type of psychosis that we come across. And when I say psychosis in this particular scenario, the psychosis is essentially when you lose contact with reality, and schizophrenia is a sort of well-recognized, one of the most common causes of psychosis, although the actual cause of schizophrenia itself is not very well known, but is associated with a certain syndrome and also certain risk factors as well. So the risk factors in schizophrenia, when you have this psychosis that is chronic, but also it can be relapsing and remitting, it can be related to lots of things in childhood. So when you are taking a history in psychiatry, you always need to ask about childhood. Have they had any traumatic events when they were kids? Were they sort of in an area where there was a sort of war or conflict or something like that? Cannabis use is of course important, maternal poor health, trauma, and interestingly, living in the city, and also if you are living in or if you immigrated to a more developed country, which is interesting. There's some data on it. I don't know why that's the case. I'm not sure people do, but that's something that we consider. So With features of schizophrenia, we sort of divide them into, there's lots of different divisions. So in the first line here, there are auditory hallucinations. And the key is that they're not visual. So visual hallucinations are not sort of considered to be related to schizophrenia. They must be auditory. Visual hallucinations, anyone who has visual hallucinations, you'd be thinking of something else. So probably in the emergency department, you'd be thinking of something like, I don't know, the drugs, basically. Hallucinogens, for example. And then you have thought disorders, delusional perceptions, and passivity phenomenon. So just going through that, so we talked about the auditory hallucinations. And thought disorders are essentially when you have thoughts, essentially can be subdivided even further into thought insertion, where the patient says that they feel that there are thoughts being implanted in them, or thoughts being removed from the patient, or thought broadcasting, which is when the others can hear your thoughts. Delusional perceptions is when you sort of see something and you make a perception that, or an insight that is delusional, doesn't really make sense. So in this particular example, I put down, I saw the Queen on television, and therefore I knew that the mafia would be set to murder me, for example. So those sort of connections that don't really make logical sense. And finally, passivity phenomenon describes a sensation of an external influence. So you feel that your thoughts are being controlled by someone or something. So those are what we consider them to be positive symptoms, which are sort of very obvious that we can see in schizophrenia. But equally, we also have negative symptoms. So we have people who sort of don't speak so much. They don't take pleasure in anything. They don't have this motivation. They have blunting of affect. So they sort of, they can't really tell you, why they're, so what the way they are, basically. And then, and that sort of, that consideration is that you always need to consider both the positive and the negative features of schizophrenia in order to take a full picture of the patient's presentation. So there are different sort of books or classifications. We tend to use the ICD-10, also the DSM-5 as well. Those are the ones that we tend to use. So here I've just put down the ICD-10 criteria, and we use that a lot in psychiatry to sort of figure out or classify different diseases. And it's probably not that important that you need to know exactly, how and what symptoms and whichever one that actually is involved or needed to make the diagnosis. It's just good to know roughly what the general features that we would consider. So we have the stuff I talked about earlier, and really I'll just put this on for reference, to be honest. And then at the end, the one last thing to mention is that it needs to be present for a period of at least 1 month. And that's a sort of general idea of schizophrenia. If someone's only had psychosis for a few days, probably might be drug related, for example, but could be other things, of course. So yeah, that's schizophrenia. Prognosis can be related to, better prognosis is related to higher education level, sudden onset, not being chronic, having a strong support network, and actually having positive symptoms. So if you have negative symptoms that is predominant, it's less likely to be, to get better, basically. And then you have this rule of quarters where 25% never have an episode, where 25% are resistant, and the other 50% is in between. So that's just good to know roughly when you tend to be asked this stuff in OSCEs. So for example, when my 50-year OSCE, a patient was like, a patient's family member said to me, what's going to happen? Is he going to get better? My brother or something. And then you just sort of go, oh yeah, actually 25% get this, and we give medication, blah, blah, blah. So those are sort of things that you think about, and they're useful for exam scenarios. Your investigations, again, this is a bit more medical. Always think of drugs. Do a CT head, MRI head to be useful, HIV, syphilis screen, drugs, and then routine blood tests. And the other stuff you might do may be more relating to sort of long-term monitoring. So ECGs, for example, be very, very useful. We'll talk about that in a bit more detail later. And that is to sort of think about when you are starting someone on antipsychotics, if they have any heart problems, they may not be able to take these antipsychotics. So that's why you would do that. And then finally, schizophrenia treatment. You treat first line with atypical antipsychotics, such as risperidone, and these tend to be the newer ones that are less likely to cause side effects. The typical ones, such as haloperidol, they can cause extrapyramidal symptoms, so that can be sort of an acute dystonia. That could be where you sort of have a complete sort of block of all your muscles, so you have a stiffness, and the classic one is in your mouth. You have this that acute dystonia that can last for a few hours or a few days. Also, you can get Parkinsonian symptoms as well. The atypical ones are less likely to give you that, so such as risperidone, and therefore they're first line. But they can also increase your risk of cardiovascular risk and your risk of stroke as well in elderly patients. So that's something to consider. you might consider giving people lorazepam if there is acute behavioral disturbance. And then if that doesn't work, there's another medication which is called clozapine, and it is sort of a next line medication. The reason we don't use it first line is because there is a risk of agranulocytosis. So you need regular full blood counts to make sure that they don't have agranulocytosis. So that's why it's next line, because it's quite tough to keep track of them, especially in the inpatient, well, actually in the community setting as well, especially if someone is not really responding to treatment. Cool, so look at the next question. All right, guys, so give me another 20 more seconds or so and go through the rest of it. Cool, let's see what people think. So 69% gone for B, and then 15% have gone for D, and then 8 and 8 on C and E, so that's cool. So the answer here is B. So this is a question designed to help you think about mental health acts, the Mental Health Act and also the Mental Capacity Act, and how to differentiate between them. So you have a 19-year-old female with anorexia, and basically the way that you need to treat her, or the method that you can treat her, is by the Mental Health Act. And the idea really is the Mental Health Act is mainly for people who have a mental health disorder, but obviously in anorexia, you have a physical problem that is a result of a mental health disorder. So that can cause some confusion sometimes. Because, for example, in patients who do not have capacity to consent for treatment or whatever, you may go on in their best interest, and that will be under the Mental Capacity Act. But in this very particular scenario, which does come up quite often, you would treat under the Mental Health Act. I'll talk about that in a bit more detail later. So the other stuff, why is it not correct? This case must be seen before a tribunal if there's a discord between opinions of the patient and doctor. Not really, because the Mental Health Act, you tend to section someone on the Mental Health Act, and in this case we feel that she is not acting in her best interest because of her mental health, and therefore we would treat her based on that. Treatment can go ahead as the patient has declined. As you know, we can certainly treat patients who against their wishes if it is in their best interest, and that tends to be under a formal process such as the Mental Health Act. And then the nearest relative can consent to treatment on behalf of the patient. So yeah, they can, but it's not the sort of, it's not the way that you sort of mechanistically go under it. You need to treat it under a formal act, and that's how the Mental Health Act has come into place. So therefore, then that was sort of towards the end, the patient cannot be treated under the Mental Health Act, so a capacity assessment must be undertaken. We wouldn't use the mental capacity assessment, we would treat under the Mental Health Act because, as I said, this is a mental health disorder. So let's talk about the Mental Health Act in a bit more detail to give you a better understanding. So you have to have certain criteria. You have to have mental disorder. You must have a risk to your health, safety, or safety of others, and there must be a treatment of some sort. And that can include drugs, can also include nursing care, particularly mental health nursing care. And then in this particular scenario, only the physical problem is a result of the mental disorder, so such as refeeding and anorexia. So there are certain sections that we use. So basically the idea is that you have someone who comes into the emergency department, for example, and then they're unwell and they're psychotic, and you don't know what to do because you need to calm them down, and you need to also treat them, and you need to assess them. So sometimes in psychiatry you need quite a lot of time to assess them, and that can range from 28 days, for example, to 6 months, or 3 months, 6 months. So you need a long-term plan, and you need a framework in order to treat under that plan. So that's how the sectioning, the word sectioning, comes from. So the different sections that we use are section 2 and section 3 are the most common. And basically, this is when you have someone who you want to bring into a hospital or a mental health setting for 28 days, and then you have to have two doctors who have to approve it. One of the doctors has to be sort of a Mental Health Act approved doctor. It tends to be a psychiatrist. So in theory, for the Section 2, it could be kind of a psychiatrist or a mental health nurse and a medical doctor, for example. And then the Section 3 is a bit longer, it's 6 months, it's renewable, and also it requires a mental health practitioner and two doctors as well, both of whom have to have seen the patient in the past 24 hours. And Section 3 is more sort of a treatment order, whereas a Section 2 is more for sort of an assessment, but also you can treat on both of them if it's required as well. So those are the two sort of basic ones that we use most often. But there are other ones. So 5.2 is when you detain a patient for 72 hours, and that can be a doctor, so a junior doctor. So that is well within your rights if you feel that's the case. But obviously, I'm not done it myself, but it's definitely something you can do for 72 hours. A nurse, 5.4, it lasts for 6 hours, so it can detain a patient under that. And then 135 is when a police can go into a property to remove a person to police station or A&E. But actually, the more common one is 136. So you see that in the emergency department where police will come in and say, we have, under Section 136, we bring this patient to ED, and then they get more assessments going forward. So that's sort of the general ones we use. There are other stuff, of course, and there are some small print about the rest, but these are the ones we sort of think about the most and come across in practice. But I have to say 5.2 and 5.4, I haven't really had to do it, but I'm sure there will be some junior doctors that have had. Cool. Next question. All right, let's see what you think. Cool. 46% have gone for D, and then what is it? 46% have gone for D, and then 31% have gone for A, and then E, 23%. Okay, cool. Fine. So the most likely answer is delirium tremens, D. So why is that the case? I suppose it could be the other stuff, but it's not the most likely diagnosis. And the reason for that is, so we have a 45-year-old chef, and he is agitated, saying his bed sheets are filled with insects, and the hospital security has been called to restrain him. He has no past medical history of note, which is, it could be an acute psychotic episode, possibly. It could be delirium tremens. Could it be nosocomial viral encephalitis? Less likely, I would say. And then Wernicke syndrome, Korsakoff syndrome, again, less likely. So the key thing that makes it a delirium tremens is that the key is on the third day of admission. So it's kind of a couple of days after he comes in. That's one. And the second thing is that the exact hallucination that he has is a visual hallucination, as it is about insects, which is like a classic thing for delirium tremens, which is basically when you drink a lot and you go into hospital, and we see it a lot actually in hospital, where someone drinks a lot, they come into hospital, a couple of days later, they're really confused and agitated and kicking up a fuss. Then the most likely in that case tends to be delirium tremens, and which is sort of acute alcohol withdrawal. So acute psychotic episode could be less likely given the stuff I talked about. I suppose in theory, in this sort of stereotypes, I don't know if in this particular scenario, when the person writing it was thinking, oh, a chef is more likely to drink a lot. I suppose in patients, we have these sort of stereotypes in single best answer questions, like chefs or people who who work very hard and more likely to drink, I guess. But in this particular scenario, it's more likely to be delirium tremens. We assume that he drinks, but obviously we can't tell from this scenario. But this is important in real life, because patients sometimes will not tell you whether or not they drink, and you sort of have to figure it out, and then you go and ask the families, and they're like, yeah, actually they drink loads. Wernicke's syndrome is less likely. You will tend to have something like the sort of triad, which is urinary incontinence and confusion, and also the ophthalmoplegia as well. Korsakoff's is a very long-term process, and that can be secondary to B1 deficiency going forward, and you can get this dementia, less likely in this scenario. And then really viral encephalitis is, nosocomial viral encephalitis, super rare, less likely. So that's why the most likely diagnosis is delirium tremens. So yeah, I used this image before, I think, because I really liked it. Alcohol kills. This is in the Wellcome Trust. And then, yeah, so the idea really, it takes a few days, peak usually day 4 or 5, and you get these tactile hallucinations where you feel like there's insects crawling under the skin, sweating, hypertension. You can get seizures. It's quite dangerous, actually. So you need to make sure that they have the medication that they need. So if they have high alcohol intake and they come into hospital, and you're worried that they're going to withdraw, you need to give them chlordiazepoxide, which is a long-acting benzodiazepine. If they have liver disease, they find it difficult to metabolize chlordiazepoxide, so therefore you can give lorazepam instead. And then when they come into hospital, you need to make sure that they have Pabronix, which is sort of a mix of vitamins, including B1, that helps to reduce the risk of Wernicke's encephalopathy, which is related to B1 or thiamine deficiency, which, if untreated going forward, can lead to Korsakoff's dementia, and that tends to be irreversible. So that's generally delirium tremens for you. Cool. Right, next question. So this is a shorter one, so I'll give you another 20 seconds. It's 40 seconds to see. All right, guys, let's see what you think. Cool, so 80% have gone for A, 20% have gone for B, which is cool. Right, so the answer is A. So yeah, so someone's got bipolar disorder, which you may have come across. So one of the biggest, bipolar disorder, and then what you need to sort of think about what the medications they might be on. So someone's got a coarse tremor and the speech has become slurred, and then one of the regular medications has recently been increased. So I think this scenario really is pointing towards someone who's got bipolar disorder, probably is on lithium, and therefore there is a higher risk of someone having lithium toxicity, which in this case is a coarse tremor and slurred speech. Interesting, actually, looking at this question now, one other thing you could think about, just for interest, is that if someone who is on antipsychotics and they have a coarse tremor and speech becoming slurred, I suppose you could consider them having a stroke as well, because it increases your risk of stroke. So regardless, urgent referral to the hospital is important. And we'll talk about why, if you're on lithium, you need to go to the hospital in a second. Reassurance and review is not appropriate because lithium toxicity is dangerous. Dantrolene is a treatment for neuroleptic malignancy syndrome, and then that is characterized by all the stuff I've just put here. It is possible, but also you wouldn't really, if you're in the GP, you wouldn't really prescribe dantrolene, and you have to get some special assessment first. Urgent assessment and attention on the Mental Health Act, not appropriate. Lorazepam, also not appropriate, for obvious reasons, because the patient is not acutely confused and sedated, etc., etc. Cool. So lithium toxicity. So the most important thing relating to lithium toxicity is dehydration. So that is the thing they need to tell patients when they start on lithium. They can have tremors, they can have dry mouth, they can have increased thirst and drowsiness. If it gets worse, the fine tremor turns into a coarse tremor. They can get CNS disturbance, arrhythmias, and it can be quite dangerous because you can get renal failure, you can get worsening dehydration, and you can get loads of seizures. So therefore, you would want to make sure that everyone is treated appropriately and assessed in hospital. You make sure to maintain their electrolyte balance, monitor their renal function, give them fluids, and then you can treat agitation and seizures supportively. If they're really bad, you can discuss with the intensive care unit for hemodialysis. Perhaps they may have taken an overdose as well. And then, of course, involve the psychiatric team whenever you can. But really, a lot of it tends to be fluids. But yeah, that is lithium toxicity. Cool. Next question. All right, 10 more seconds, guys. Let's see what you think. 54% have gone for D, and 31% have gone for C, and then 15% have gone for E. Cool. So 18-year-old, tired, exercising a lot, losing weight. She believes she is fat. That's important because that's one of the sort of cardinal features of anorexia, in the sense that if you have this belief that you need to lose weight or that you are overweight, and that's sort of one of the diagnostic criteria. I'll talk about that in a sec. Restricting calories, doesn't want to gain weight. She's markedly underweight with lanugo hair. What's the most likely finding on routine blood tests? So the answer is actually C, low white cell count. So I think perhaps this is slightly niche, I guess, because it's just something. It's just, I'm mainly using this question to show you about the other stuff, so that you know. And I think it's really useful because a lot of you said that it's actually high potassium, but really it's always, not always, but it's very much going to be low potassium. And that's probably the most important learning point from this scenario. So you have patients who have anorexia or not eating enough. They will invariably, or at higher risk of having a low potassium because they're not eating enough. They will have a low glucose because they're not eating enough. And they have a low platelet because they are not sort of making enough, not able to sort of do the normal bodily functions as they normally would. And that's the same sort of idea with white cell count. So platelets and white cell counts to a certain extent come hand in hand because you're not able to make the same sort of cells and stuff that you would normally have. Lower urea probably is not really that relevant. I suppose if you are very low weight, you may have a low creatinine because it's related to muscle mass. There is a strong relationship between muscle mass and weight, but also you may have a high creatinine, for example, or high urea if someone is in renal failure because they're dehydrated. So that's something to take into consideration. That's why it's sort of not the most likely finding, as it were. It's mainly likely to be low white cell count. So anorexia, so you have a deliberate weight loss. You have to have concerns about weight and shape, fear of becoming fat, and it is this, what we call an overvalued idea, in the sense that you sort of know perhaps that it is not in your best interest, but you value it a lot and you sort of think about it a lot, and rather than a delusion when you sort of don't actually know that it is not really related to reality. You sort of, whereas in some people with anorexia, for example, at least from my own experience of seeing patients with anorexia, sort of know that it's not good for them, but they do it anyways. Whereas in delusions or in psychosis, they don't know that what they're doing is not related to reality. So that's just some kind of psychiatric terminology to take into consideration. There are some risk factors, and you have, it can be related to maternal encouragement of weight loss, family histories, other disorders, and certain at-risk professions. And what you get is they can either not eat or run a lot, or excessive exercise, use laxatives and vomiting. But of course, you can sort of it can come hand in hand with bulimia versus anorexia. So sometimes it can be blurred, but in this case, we're just focusing on anorexia for this lecture because it's the sort of most common, as it were. But actually, bulimia is common as well. But we're just, because this is the sort of thing that does come up a lot in exams, and also there are lots of physical features that are useful to take into consideration. So the features we talked about: low BMI, reduced muscle power. So one indication that they're quite severe is that they cannot actually use their proximal muscles to get up from the chair. So if you get at them to sit up with their hands like this, it may be quite difficult, and that's an indication things are becoming quite severe. They can have lanugo hair, they can have amenorrhea, and the hypokalemia is very important. You need to monitor for that. And the key is to make sure to do ECGs as well to check that they don't have prolonged QT syndrome, prolonged QT on their ECG, and that they are at risk of arrhythmias and getting worse. And then there are other things that are relating to their sex hormones, growth hormones, and you can get a high cholesterol. I don't actually know what the mechanism is for the last three. I'm not sure you need to know. I think hypercholesteremia is related to the fact that you sort of in sort of an excessive starvation response. But yeah, feel free to look it up because but I really don't know. But it's just if you're interested in this, of course. Yeah, so you need to make sure that you don't have sort of the refeeding syndrome, where you can have sort of low phosphate, low potassium, low magnesium, or you need to sort of replace that. So that's very important, especially if someone hasn't eaten for a while and you want to replace their sort of electrolytes. Monitor for cardiac arrhythmia is very important. Psychological therapies. There isn't really any drug therapy that's used commonly in anorexia, as far as I'm aware. And then also, if things are really bad, in specialist units, they can consider NG feeding. But generally speaking, in someone who has anorexia, it tends to be dealt with in a medical sense by specialist units. So that's, as a medical student, I spent some time in an anorexia unit, and it's very, very interesting. But obviously, it's not stuff that you need to know very often. But it's more important to know about the basic stuff relating to their medical issues in the initial stages, and also the long-term sort of diagnostic process that you might consider in anorexia, and the features on examination. Cool. Next question. Okay, right, let's see what people think. So that's in question. Are we getting there? Yeah, so another 10 seconds. Cool. Let's see what people think. Okay, so 46% have gone for olanzapine, and then 23% have gone for sertraline, and then 15% have gone for B, and 8% C, and 8% on E as well. So someone has walking on the roof ledge, practicing flying, says she was about to practice flying, fixed belief that she's able to do this, move around, very agitated, seems elated, urine drug screen is negative, routine bloods are normal. She had a severe depressive episode 1 year ago, and then a similar set of symptoms. What's the most appropriate first-line pharmacotherapy to deal with this episode? So the answer is actually olanzapine. So the key aspect here is that you have someone who has a fixed belief that they're able to practice flying, they're elated, agitated, moving around the room. So you're thinking, could this be a manic episode? And this sort of idea, I think what they're getting at in this particular scenario is that you have this like, not necessarily, but just as a thought process, you could consider them wanting to practice flying is this like delusion of grandeur, as it were, where you sort of think that you can do a lot more, or you are, and in sort of more classical instances, you think you're a king, for example, or a ruler or a president or whatever. Whereas in this scenario, perhaps that's what they're getting at. But generally, even without that, you can sort of probably figure out that they probably have a manic episode and they had a previous depressive episode. So you're thinking, could this be bipolar disorder? And you've got someone who is, in hospital, not safe to go home. What would you give then? And this is key because in bipolar disorder, you would consider giving, there is a big difference between acute therapies and also in chronic therapies. So for example, lithium and valproate are used in bipolar disorder, but they tend to be used more sort of down the line in the chronic setting when they are a bit more stable as stabilizers, mood stabilizers. Sertraline is more for depression and anxiety. We don't really see that much here, but she's had one in the past. And clozapine, as we talked about earlier, is a sort of tends to be an antipsychotic that used later on in schizophrenia because it has a risk of agranulocytosis. So it's definitely not the first line pharmacotherapy to deal with this episode. So bipolar disorder, you tend to need, or to make a diagnosis, you will need either at least one episode of a manic or a hypomanic state and one major depressive episode. And you can have sort of less, the hypomania is sort of a less severe version of mania, and then you can have sort of a depressive episode. And if you sort of go between hypomania and minor depression, that's known as cyclothymia, just out of interest. But generally speaking, you have to have either manic episode and a depressive episode in order to make the diagnosis of bipolar disorder. And the difference between mania and hypomania tends to be that in mania, you really can't go on and do your daily activities and live normally. Whereas in hypomania, you can sort of get on with it and you can have evidence of elation that keeps going for a while, but you can sort of keep doing what you're doing for the most part. Rather, where there's mania, you're sort of completely out of touch with reality, as it were. So yeah, that's just generally what I was talking about earlier. So this elevated self-esteem, increased rate of speech, flight of ideas, easily distracted, agitation, high risk of danger activities, and then hypomania, not severe enough to cause marked impairments in social occupational functioning, and then depression, which we'll talk about in a bit more detail later. But generally speaking, weight loss, energy, feelings of worthlessness, trouble thinking, suicidal ideation. We'll talk about that in a bit more detail. So with your management, you need to, in the acute stages, you would tend to give a, if someone is very agitated, you may consider giving intramuscular neuroleptic or an antipsychotic as well, or a benzodiazepine. If without agitation, you could just give someone oral monotherapy or an oral antipsychotic, and then you can add on later stuff like lithium or sodium valproate, which can be used. Whereas if someone is depressed, you could then consider giving lots of other stuff, but probably that's not so important. I think that's a bit more specialist. But generally speaking, they're at high risk of relapse. They are all tend to be at high risk of relapse, and then you may consider treating with lithium or valproate, and then also antipsychotics as and when in treatment-resistant cases. But again, this is more specialist. I would just remind you mainly of all this is that if they're acutely agitated, tend to consider antipsychotics. If they're sort of on the chronic stages, you then consider giving lithium and valproate. I think those are the main learning points from that question and bipolar management generally. Cool, next question. Right, let's see what people think. So we've got, yeah, I'll give you a bit more time. Maybe another 15 seconds or so. Okay, let's see what people think. So 58% have said D, and then what was it? C. 25% have sent C, and then constricted pupils gone for E. So what is the answer here? Agitation. Cool. So you have someone who is feeling unwell, drowsy, confused, taking a substance but won't say what. That happens sometimes. Constricted pupils, and there's needle marks. What's the most likely to suggest when he's entering into a withdrawal state from the substance? So this is really sort of pointing towards you seeing someone who potentially has a withdrawal of some sort, and possibly, he's got needle marks. Could this be something like heroin, for example, which is potentially quite common? And then it's just trying to sort of show you what the withdrawal state could look like in patients who have opioid withdrawal, which can be very important. And you can come across it quite often, and even in patients who haven't been having their morphine, for example, for whichever reason. So I won't go through in detail, I'll just talk a bit more about the opioid withdrawal in general. But the constricted pupils, just for interest, tends to be related to people who are having morphine. So the sort of pinpoint pupils are related to morphine use rather than withdrawal, just out of interest. So opiate withdrawal, the key one, especially in the exam scenario, is this sort of everything runs a lot. So sweating, watering eyes, rhinorrhea, yawning, GI upset. So rather than constipation, which is what morphine tends to cause, they will cause more like diarrhea, anxiety, irritability. So it can happen whenever, but really as early as 6 hours after the last dose, but can happen later on. But the key, I think, is that unlike alcohol withdrawal, it's not dangerous, but it's obviously unpleasant to the patient, whereas alcohol withdrawal can kill you. So you don't really prescribe much in withdrawal. You sort of either give, so this is what NICE say, you can give lofexidine, which I've never really seen, to be honest, on the ward. Never really prescribed it myself, but that's what NICE said. But probably more likely is that you would give something like benzodiazepines for agitation and antiemetics for GI symptoms. So generally speaking, you don't really do that much. You sort of treat supportively. And apparently NICE says give lofexidine, but I've never come across it myself. It probably will depend on your own hospital guidelines. So do have a look at that if you do have any guidelines on that. So that's something which is useful. Cool, next question. Right, so let's see what people think. Cool, so 86% have gone for B, sertraline, that's cool. So she's 24-year-old, she's got postnatal depression, and she likes to start antidepressants. She's keen to continue breastfeeding. So the answer is sertraline. So this is sort of stuff that comes up quite a lot, I suppose, as you grow further in the course, the relationship between different specialties. So the key is sertraline. So the key is sort of the fact that she is breastfeeding, and therefore you want to give her something safe. And really the safest one in this scenario is going to be sertraline, because it's minimally present in the breast milk. So the sertraline and paroxetine are the most appropriate SSRIs for breastfeeding. And just I thought to make this a point about other stuff. So for example, cardiac patients, there have been trials that show that, I think it might be called the SAD Heart trial, if I'm not mistaken. And it showed that sertraline is the best for cardiac patients who have had myocardial infarctions in the past, and sertraline for a safe ticker. Whereas in like more younger, in pediatric patients, I think fluoxetine is the one that we use more likely. That's the one that's sort of cleared for that patient group. And the other ones are not really appropriate. So lithium, you wouldn't use St. John's warts, not really the sort of most appropriate first-line treatment for depression in any case. And then selegiline is, I think, a very old school one, as is doxepin. So we wouldn't use that. SSRIs tend to be the ones that we use the most to start off with for anyone who has depression. So depression is very common. These are lots of the different things that you might see. Very, very common in in the UK and the world. But just for, you may have come across these a lot in your reading. I use this mnemonic, which you might find quite useful: SAW, email, sleep, appetite, weight, energy, mood, activity, irritable, libido, not libido, and suicide. And it's quite useful to sort of run through this when you're taking a psychiatric history in depression, for example, or someone who feels like they're depressed, asking about all these things. So it's quite good to have a mnemonic in your head. And then very, very important to always ask about patients if they've had any thoughts of death or suicide, or have a suicidal plan, whether or not they have a firm plan, or is it just sort of fleeting thoughts. It's very important because that will help in your risk assessment for any patient who comes into hospital or the GP practice. Obviously, I'm a medic. We think about organic cause of depression. The most common is probably Parkinson's, and one of the most common mental health disorders relating to Parkinson's disease. Also, people with dementia can be depressed as well. It's difficult to tell whether or not it's actually related to the dementia itself, or whether or not they are it's a reaction to their dementia. But also multiple sclerosis as well. Again, is it the disease affecting the brain, or is it the reaction to that? So, and then there's other stuff as well. Endocrine disorders. I think all of the stuff's technically quite a small print to a certain extent. I guess the only thing I would mention that is of very important, of a lot of importance, is probably steroids, because steroids can cause a lot of psychiatric problems. So, especially in elderly patients who have been started on steroids. So, steroids can cause psychosis. Steroids can cause depression. And if you give, being on a medical night shift, someone in the morning comes in and they give them steroids, and then in the middle of the night they can't sleep and they're agitated and confused, probably the steroids. So take that into consideration when you are all junior doctors. It can be frustrating sometimes because you don't know what's going on, and then you look at the medication list and you're like, oh, okay, probably steroids, let's stop that, for example, for now. Cool. And fine. And then the management of depression is, so this comes a lot. I suppose people think about this a lot because it comes up in exams, and there's different sort of nice guidelines to it. And then basically, if you're, especially in the GP practice, when I was working in GP, you initially start off with low intensity interventions, and that can be this IAPT, improving access to psychological therapies. So they go see a psychologist, and then they are able to seek help and possibly have group-based CBT. So that tends to be first line. Second line can be pharmacological therapy like sertraline, and or cognitive behavioral therapy. The key things when you're starting someone on SSRI is that you need to keep them on the SSRI for at least 6 months after remission to reduce the risk of relapse, and you shouldn't stop it straight away. You stop it gradually. And then if someone is actively suicidal, or they have suicidal plans, then you must refer urgently to the psychiatric team in the community or in the hospital. This is Beck's cognitive triad, which is a method of thinking about sort of CBT and how to consider CBT. And this is, the top one is negative thoughts about the future, and the bottom right is negative thoughts about the world, and then this emoji on the left is negative thoughts about yourself. So that's the sort of thought process that we have when someone has cognitive behavioral therapy. It's cognitive triad. So yeah, just out of interest. So yeah, and then severe depression, you can consider SSRIs as we would. SNRIs, mirtazapine, can help sometimes with improving appetite. Lithium can be used, and then made famous in certain Hollywood films many years ago, electroconvulsive therapy is still used in patients who have severe depression. One of the risks is that they have a persistent memory loss, so you may have to do an MMSE, so mini mental state examination, before and after to see if they have memory loss. And when I was doing psychiatry as an FY1, I was able to see it. And yeah, it's they need to be sedated, and they have an anaesthetist, and sedate them, and there's a psychiatrist and an anaesthetist, and then they do pre and post tests. So yeah, that's how we treat very severe depression. Cool. Let's have a look. I think it's the last maybe question, or last two questions. Cool, all right, 10 more seconds, guys, to see what people think in the next 5-10 seconds. Cool. Right, what do people think? Cool, so 46% have gone for B, and then 31% have gone for E, 15% have gone for A, and 8% have gone for D. Cool. And what's going on? Oh yes, please fill out the feedback form for me so I know what you guys think of the questions, the images, the new images, and also what else? The timing, very important. So we'll try and stick to time today. The answer is acute stress reaction. So there's lots of stuff relating to anxiety disorders, and there's quite a lot of content to go through. I'm going to try and pick out the important stuff. I'll leave some stuff for you to read about later when I upload the lecture. But the key aspect here is that he has a recent stress thing, which was the violent mugging he had 2 weeks ago. Minor injuries, he's been very anxious, avoid the park near his house where the crimes occurred, and he feels incredibly distressed. He can't remember the mugging, feeling it was a dream, and talks about feeling numb and unreal. So that's the sort of idea of like depersonalization, derealization. And the reason it's not post-traumatic stress disorder is that you need to have a longer time frame. So post-traumatic stress disorders tends to be like after 6 months or something like that, after the initial incident. Whereas if it's something acute in the past couple of weeks, it's more likely to be an acute stress reaction. Reactive depression, there isn't really much in the way of depression. There are obviously some slight features, but not the most prominent. Panic disorder, we'll talk about that in a second, and phobic disorders, talk about them, but generally speaking, he doesn't have a phobia of anything in particular that is constant and keeps happening and has been going for a while. And equally, panic disorder, he's not sort of having episodes of panic attacks, so that's likely. That's why it's acute stress reaction. So a generalized anxiety disorder is the most common, but there are other stuff: phobias, panic disorder, obsessive compulsive disorder, post-traumatic stress disorder. I'm not going to go through all of them in much detail. I'm just going to focus on a few key ones because obviously it's a very big topic, but perhaps if there's interest, I may do a full anxiety lecture, which hopefully will be useful. So there are certain features which come across, and I think it's very important because you will come across a lot of this when you are in medical practice and you see patients who have these sort of features. A lot of it will come in patients who are very anxious, who might have chest pain, and they're very young and they have constriction in their chest, and you have to assess them. So you really, if someone has chest pain and they're coming in and they have risk factors, you need to assess them even if you might think they are anxious or they have anxiety issues, you still need to assess them, do an ECG, possibly do a troponin, do further investigations, and it's quite difficult to tell where the physical and the physical and psychological stop and how to differentiate them. So you tend to have to do a lot of investigations in certain instances, but then if you have recurrent attenders who come in with the same issue, and then perhaps you may not want to investigate further and do more invasive investigations. But again, it's every single patient is different. So, there's quite a lot of features here. So in that sense, it can be anything. So, motor symptoms can come to a neurologist, GI symptoms can come to gastroenterologists, chest pain for cardiologists, respiratory physicians, patients with asthma who are anxious as well. So, it can happen to every, these patients can present to any specialty, and therefore you have to have an understanding of how to address these concerns and use appropriate methods such as ICE when you are in clinical practice, but also when you are in your exams as well. And maybe we'll dedicate a session to that going forward because it's very important. So generalized anxiety disorder, it generally is sort of what it is. It is what it is. It is a generalized anxiety disorder. You have general anxiety about lots of stuff, feeling on edge, difficulty concentrating. You get this autonomic overactivity with some of the stuff that we mentioned earlier, with depersonalization. The other key thing I would mention about this is that it's very important to make sure you have the right exclusions. So exclude stuff like hyperthyroidism, substance misuse, excess caffeine. Also depression can be mixed in within anxiety. So you can have a mixed depression anxiety disorder. That's what I'm going to say about GAD. Panic disorder. This is important again medically because you have patients coming in with panic disorder, where they have recurrent attacks of severe anxiety, and they have this fear of dying or losing control or going mad, lasts for a few minutes, and then between attacks they tend to be free from anxiety symptoms, but you can sort of think that it's coming on, and the way that they come across is that they would have breathing difficulties, chest discomfort, palpitations, but the one of the more medical ones that we find is that people will have tingling or numbness in the mouth, and that tends to be relating to hyperventilation. Increases your pH, and then what calcium tends to bind to albumin, and at least the hypocalcemia. So your hypocalcemia leads to this localized tingling or numbness in the hands. That sort of is sort of pathognomonic, or sort of more likely, obviously not definite, but perhaps points you more towards this diagnosis. But obviously every patient is different. And then phobias. Phobias are, you may have come across it in popular culture and also in your clinical practice, and you have very common ones that can be for spiders, for example, for flying, for high places, and then the other one is agoraphobia, when you have a fear of being in a public space, and then you can also have social phobia, sort of meeting with people as well. The agoraphobia tends to be related more to sort of crowds. So it's not sort of, and I think agora, if I'm not mistaken, does it mean, I think it might be the Latin or the Greek word for market, I'm not sure, but just generally the sort of idea that you're in a space with lots of people around you, the crowds really, whereas social phobia tends to be in a small group and you want to sort of avoid these social situations, and then maybe also specific to public speaking as well. Tend to be slightly difficult to treat, I guess, in the sense that sometimes you can have delays until diagnosis, but it tends to be talking therapy that treats it, and that tends to have, I think, quite good results with talking therapy, CBT type stuff. But again, so that's sort of beyond my understanding of phobias. Hopefully you can do some reading about that, and I think we have some notes on it in the quest book on our website as well. Cool. So, oh, how exciting! We've done almost in 1 hour. Good. So we have. Please ask me any questions. Tell me what you think about the lecture. Please give us feedback so that I know, and then we will do an anxiety lecture, of course, out of interest. And yeah, no, thanks. I hope you liked it. I've not really done a psychiatry one before, but yes, excellent. Agora is market in Greek. Thank you, Nico. Yeah, so I did psychiatry as an F1, and I did also general practice with a lot of psychiatry, and also in medicine we see a lot of psychiatry. So how do you know when to use ICD-10 or DSM-5? I don't actually, I'm not really sure, to be honest, when we use either. I think in the UK we tend to use ICD-10 the most. I'm not really sure why we use either or, to be honest. Try and look it up, actually. I'm sure I can find it on any psychiatric, what do you call this? Any psychiatric resource. Yeah, sorry, don't know. Cool, but yeah, thanks very much for coming. Was there anything you wanted to add, Savannah?
No, all good.